Good day, everybody. My name's Martin Kiernan, and I'm delighted to host this Weber Teleclass. The topic today is Patient Safety Begins at the Front Door, Infection Prevention in Home Health and Hospice. And joining us as our presenter is no stranger to teleclass education. It's Mary McGoldrick, who works for home care and hospice, home care systems as a home care and hospice consultant. Mary's worked in home care for a long period of time. She's been a hospice and home care surveyor for the Joint Commission. She's had a period as an adjunct professor for 5 years at Mercer University's Graduate School of Business and Economics. She's also been inducted into the American Academy of Nursing for developing infection prevention and control guidelines and standards for home care and hospice providers. This is a really important topic, and as certainly in the UK, we're seeing care moving from hospital settings and primary care into primary care settings and people's care in the home. This is going to be very important going forward. So I'm delighted to host Mary, and welcome, Mary.
Thank you, Martin, and welcome everyone to this Weber Teleclass on Patient Safety Begins at the Front Door, Infection Prevention in Home Health and Hospice. So over 30 years ago, I was invited to be a co-author of an APIC endorsed book called Infection Control in Home Care and Hospice because of my home care background. And saying yes to that opportunity changed the trajectory of my career. Of course, I've still been in home care, 4+ decades at this point, but infection prevention and control is a very important topic in home health and hospice, and one that I'm happy to speak with you about today. So let me tell you a little bit about our learning objectives and specifically what I'll be reviewing with you. So for the past 35+ years now, I have been doing mock surveys for home health and hospice organizations. I'm very much boots on the ground, out making home visits, conducting, total, mock surveys. But a big piece of that, a very important patient safety strategy, is watching the staff, as they're providing care in the home, looking at their supplies, and looking at how they are going to prevent the transmission of potentially pathogenic organisms in the home, because that's most important. But during my travels over these decades, I have seen absolute trends in problems that staff are making when they're out there providing care to the patient, specifically in the home care setting and some in a hospice IPU setting. So the purpose of this presentation is all about patient safety, but hopefully you'll also be able to pick up on some tips to help you prepare more effectively for a CMS Medicare survey or any accrediting body organization survey here in the US. So for those of you that may not be familiar with home care, providing care in the home is totally different than in a healthcare setting. You can see with some of the images here, the top right corner, you can sort of see the oxygen concentrator in the back, the tubing that's, draping over the newspaper stained, newspaper that's stained with, pet excrement, if you will, on the floor. We can see some of the home environments that we have to work in, but it really is very unique. Probably one of the most unique things is that we have to transport all of our supplies, our storage, hand hygiene, vital sign equipment, PPE. We have to, bring all that stuff into the home. We don't have, we're not in a facility building. So the other unique thing, when we generate medical waste in the home, we have to, either dispose of it in the home or transport it safely back to the office. And we have no control over this environment that we are working in. And that honestly is one of the hardest things. And I always try and put myself in the staff's shoes when I'm with them making visits, because some of the home environments, they're very resource limited. The patients and the families are doing the very best that they can to provide care in a safe manner for their loved ones in the home. And our staff have to go in and adjust to those settings. There could be, the pets, excrement, pests, rodents, their excrement. Some people don't have proper utilities, major appliances. Some of the medical equipment availability is very limited. And one of the big things is we don't have a housekeeping department going into their home, that's going to go in there every day and clean everything up and disinfect things. And so it's certainly a very unique aspect of providing care in the home. Now, one of the cornerstones of patient safety is hand hygiene. And we talk about, that patient safety, infection prevention begins at the front door, and it absolutely does. If you look at the left-hand side, or these are the US CDC guidelines as to when hand hygiene needs to be performed. And the first indicator is before having contact with the patient. And so right as we come in the door, to greet someone, with a handshake or a hug or whatever, but we are going to be having direct contact. It's typically, shaking hands, whatever. But we then, if we don't perform hand hygiene, is we are, before we come into the home, we are going to transmit those organisms directly to the patient because they typically don't wash their hands right after shaking our hands. So like when I'm making home visits, I have sort of a little clip-on hand sanitizer product that I use. I make sure that I'm sanitizing my hands before, I walk in the door. I'm not touching doorknobs anyway. I'm just walking in and greeting them so I'm not passing along my organisms. So that's something that home care staff need to be very aware of. Anytime we go back to the patient, we're going to be, we check vital signs, whatever. We go back, we document them. We go back to the patient to then auscultate their lungs. We have to perform hand hygiene again. So all of this back and forth, these are, when it's indicated, and organizations are absolutely cited, it is problematic and something for you to be aware of. Staff do a good job before performing an aseptic technique, draining a, Foley catheter, whatever. Staff are good about that. After contact with the patient's environment, maybe, we walk in, the TV is so loud, we can't even barely, have a conversation. Touching the TV remote, we have to perform hand hygiene again before we go back and talk to have direct contact with the patient. After contact with their blood, body fluids, staff are good on that. Again, good on moving from soiled body area to a clean. That's all good. But immediately after removing gloves, this is a very common opportunity that staff are not consistently performing hand hygiene. One of the common procedures that we perform in the home care setting is our nurses going in to perform complex wound care on patients. And some, the nurses go in, they do a good job. Some of them put their hand sanitizer on the field. They have everything prepared, ready to go. And every time they change their gloves, they need to be immediately performing hand sanitization, and they miss it. And they just go right into changing gloves, and they miss that opportunity. And we know that there can be, microscopic holes in the gloves, and that's why it's important to do that immediately after the glove removal. So that really is a very common finding for home care organizations. And then we have the World Health Organization's hand hygiene moments. And moment number 2 is actually the most important. That is the one where we are most likely to transmit a healthcare associated infection to our patient. So please be aware of all of these hand hygiene opportunities when you're caring for patients. Now, not only are we supposed to perform hand hygiene using the correct technique, but we also, or when it's indicated, but we also need to be performing using the correct technique. It's really both of these areas. So you might have performed it correctly, when it was indicated, but this is a common area that people don't do correctly. Now, there is sort of a sacred cow in home care that it's sort of an old holdover. It's slowly going away, but there's been the thought that when you walk in someone's home, this is in the US, that you must wash your hands with soap and water as soon as you enter. You don't have to. Using hand sanitizer is perfectly correct as long as one of the indications for using a hand sanitizer, is not met. But generally your hands are not soiled, wet, whatever. It's perfect to use the hand sanitizer. I'll tell you from doing mock surveys for people, it's the hand hygiene with soap and water that's more cited. So it's usually the steps in the hand washing process that are missed at some point. So, you're supposed to, wet your hands, apply the soap, wash your hands, following, covering all the surfaces. We'll talk about that. But sometimes staff immediately, they put the soap on the hands, then they put it, let the water rinse over, and they're rinsing the soap down the drain. I've seen survey reports from organizations that get cited for that. So, once you wet your hands, you put the soap on the hands, then you need to start vigorously scrubbing for a minimum of 15 seconds. That's what the US CDC guidelines state, minimum of 15 seconds. It's not, 15 seconds and you're done. Now, when I'm with a staff member, I'm sort of counting to myself 1001, 1002. Sometimes I don't even get to 8 or 10, and they're rinsing their hands, they're done, they're drying, and they will get cited for that, for not performing hand hygiene for a sufficient length of time. The hand drying activity is also important for hand hygiene because when we are drying our hands, we are also removing additional organisms from our skin that are on the transient bacteria that are on there. We're removing them from the upper layers. It's important to pat dry, but you want to make sure, like the picture of the cat here, not using used towels that are in someone's bathroom. I hate to say it, the towels that are hanging in the shower, we don't know where some of these have been. If the wife comes out and says, and I've seen this, oh honey, I put out a fresh towel for you, that's fine. But generally in the US, we should be bringing in our own hand hygiene supplies, paper, hand drying material, and using them because many of these homes are resource limited. Paper towels can be expensive, and we do need to be using and bringing in our own hand hygiene products and supplies. Now, sometimes when you're going into someone's bathroom, there's no place to put these paper towels down, and I see the staff, they take those trifold towels and they put them under their armpit and they walk into the bathroom, so that their hands are free, if you will, to perform hand hygiene. Please don't store your paper towels in the fold of your armpit. That would not be the appropriate place to then use those to then dry your hands. So you want to make sure that you are properly drying your hands, that your hands are dry, because sometimes people are barely drying their hands and then they're trying to put their gloves on and they can't imagine why the gloves are not going on. Now, when the staff are washing their hands with hand sanitizer, one of the common problems is that not all surfaces of the hands are covered. This particular graphic shows the areas that are most frequently missed. It's the thumbs, it's around the nails, and between the webs of the hand. So when you are performing hand hygiene using a sanitizer, please be aware of these areas, because I'm watching and I do see this. So this would be important. And then again, rubbing your hands together until they're dry. If your hands, when you are using the hand sanitizer, if it's dry in less than 15 seconds, you did not use a sufficient quantity of hand sanitizer on your hands to effectively perform hand hygiene. We have to have the proper volume of hand sanitizer on the hands to kill the organisms that are on the skin. And sometimes when I see the staff, they're getting ready to, say they need to go back into their bag for some reason, and they're doing a, quick whoosh whoosh hand sanitizer. They are not getting to 15 seconds. They're barely putting it on and letting it dry, and then they're continuing on with their activities. That would not be sufficient. So we've got to make sure that you're really doing a good job covering all surfaces. Also, too, if sometimes, and this is a good question to ask your staff. Again, it's okay to use the hand sanitizer consistently throughout the visit, but your staff should be able to answer the question, when would you not use your hand sanitizer? And they need to be able to answer that. They need to know that if their hands, that they became wet, soiled, whatever. Because sometimes, like when the aides are bathing patients, the water might leak under the gloves. And then they're using hand sanitizer. If your hands are wet, you cannot specifically use the hand sanitizer. Also, too, if a patient does have C. diff, you can, in the US, you can use, I'm talking about the home environment. We're not going to have an outbreak in the home environment. Perhaps in a hospice IPU or other facilities can have outbreaks, but we don't have those in the home setting. But in a non-outbreak setting, it is sufficient to use hand sanitizer, but before you leave the home, really do a meticulous job of washing your hands with soap and water to remove all of those spores before you leave the home. Now, in home care, we have to bring in all of our stuff. We have to bring in all of our supplies. So one of the things that I'm looking for when I'm auditing the staff on their visits, I'm checking, can I see your bag? We're not doing this in the house. I do this either before the visit, after the visit. I'm trying to see what, products did they have with them and what are they in possession of at the time of the home visit. So I'm looking for, soap, hand sanitizer, and some paper drying material. Those are the three things. And a lot of times the staff, they only have the alcohol-based hand sanitizer product. They don't have any soap with them. So that's, important that you have all of those with you. Sometimes I'm with the staff and they're caring for a patient that has a drug-resistant organism, and I check their hand sanitizer at the end of the visit, and guess what? It expired over a year ago, and they didn't know that it expired. And so all this time, they might have been doing hand sanitizer, using the correct technique with the correct indications, but the product was expired. And I do see this commonly. So this is something that is more common than you'd like it to be, but it is a problem. So please check your expiration dates. If you don't see an expiration date, it's probably worn off. Take it home, use it at home. Don't be using it when you're, making home visits. Get a fresh bottle and make sure that that's always visible and that you are specifically checking that and that you've got all of the proper, supplies with you. Now, as far as some of the purchase considerations, with actually in the World Health Organization's guidelines also and US CDC, they're both Category 1A guidelines, if you will, that staff have to have access to hand lotion or cream. In our home care bag, it's prime real estate, and so we don't have room for extra stuff, if you will. And so I always tell people when you're picking a product, just make sure that you are purchasing a product with, aloe, lotion, vitamin E, I don't know, any kind of moisturizer, emollient, anything that's already built in, because then you will be meeting that ingredient requirement, because we want to protect the skin on our hands, because dermatic skin can naturally have higher bacterial counts regardless of how well we perform hand hygiene. So that's really important that we protect our skin. Also, for those of you in the US, maybe warehouse shoppers, be aware of buying large containers of soap to refill, because that would not be the proper method, and we will talk about that, but just be aware of that. And again, there is no laws, regulations that you can't use a patient's supplies in the home, but to meet OSHA requirements here in the US, we have to have all of our supplies and bring them in. We should not be using someone's bar soap that was in the shower. I've seen that. We should also not be using the soap from the decanter at their sink. We don't know how many times, we don't even know how long the soap's been in there. Soap can become contaminated. And the patients, they're probably just topping it off. They're probably not managing the proper, the container, probably the soap. So don't be using the patient's soap. Don't be using the patient's towels or paper towels unless they're giving you fresh new ones, and that's appropriate. But use that on a case by case. But really make sure that you have your supplies and be aware of these resource limited environments. Now, as far as the product management, I mentioned the soap. If your soap containers, you're using it, it starts to empty. In order to meet the US CDC guidelines, you have to empty, wash, dry, and refill that soap container. I mean, who's going to be able to do that? The size of the opening of that soap container, it's probably the size of a nickel or a quarter. There's no way you're going to be able to do that. It's best for you not to refill your soap. Get a new product, from the home care hospice provider, and then use that. Don't be refilling that soap container. The other thing too, the product that's used is make sure that here in the US that you are using an alcohol-based product and not a product, again, not that it's not going to work effectively, but the benzalkonium chloride, some of the other active ingredients, we want to be using an alcohol-based product. Now, for the storage of the hand sanitizer, we are storing our products and supplies not only in our home care bag, maybe on our person, but we're also storing those in the trunk of our vehicle. And we need to be very aware of storage, the temperature, the temperature in the location where it's being stored. I am actually based here in Naples, Florida, in the United States. It gets very hot here. And if you look at the manufacturer's instructions for use on temperature, storage, it's supposed to be below 110. Okay, it's probably going to be below 110 in your bag, but not in your trunk. In the hot season, no. If you have temperature extremes, you really should not be storing products in the trunk of your vehicle, and being very aware of that. This particular image, it shows the bottle, it's swollen. That's the thing that you should look for, that this has been exposed to temperature extremes. Get rid of it. You don't even use it. Throw it out. The alcohol is probably degraded. The expiration date, we talked about that. Make sure that that is present. Now, alcohol containers you can refill, but here are some of the problems that I see with that. They're refilled into a container with no label, or they're refilling it into a container that's labeled as expired. That's usually the first question I ask someone if I see something expired in like 2019 or something. Have you been using this before? Whatever it usually is anyway. Or they're mixing up containers. They're putting product A and refilling it into product B. You have to have the same manufacturer's instructions on the labeling. Don't be commingling, mixing, whatever. So just be aware of that. I talked a little bit about paper towel management. Store your paper towels in a plastic bag. Don't put them directly in, just like your gloves, don't put them directly in a pocket, or clothing can become contaminated. But please be aware of the manufacturer's instructions for use. On the image on the lower right-hand corner here, you will see this particular manufacturer requires hand washing to be performed after every 7 to 9 applications. And the staff are typically not aware of that. So please be aware of that and make sure that you're following that, because that's hard to keep track of how many times I wash my hands. Anyway, okay. Some other hand hygiene considerations, jewelry. That it really should be minimal. The image of this home health nurse that I was out with, there's no magic number, but in my opinion, the thumb, there's probably too many rings on there. We really want to keep our jewelry to a minimum. In the US CDC guidelines, nail polish, as long as you're not in a high-risk setting, which home care and hospice would not be considered one, freshly applied nail polish would be acceptable. Generally, after about 4 days, the bacterial count increases. But, the bottom line with this, the artificial nails, the nail tip length, it all is based on your policies and which guidelines you are going to follow. With the World Health Organization guidelines, absolutely no artificial nails. The CDC, again, it'd be based on your policies and how those are written. But the bottom line best practices, short, natural nails with no polish is going to serve you best in reducing the transmission of healthcare, of potentially pathogenic organisms. Okay, so let's talk a little bit about bag technique. This is also another unique aspect of providing care in the home. Now, this bag is a non-critical item. It is never going to have contact with your patient. It's usually on a surface in the home, but it is, a means under which, we're bringing this bag from home to home to home, and it can actually, if it's not managed appropriately, transfer potentially pathogenic organisms to someone's home. Organisms that, a lot of these patients are homebound, they're not going out. And it weren't for our equipment and supplies that we're bringing into the home and how we're managing it, we're now transferring organisms into someone's home, and these might be organisms they would never be exposed to. So we need to be absolutely aware of how we are going to manage our bag in the home. Now, here are some just general best practices for bag technique. Hey, this is a typical home environment. We go in, we try and find the best place that we can, and sometimes it's very difficult to find a place. This was an aide visit. This aide did find a little corner on the couch. You can't tell, but there is a surface barrier underneath the bag, not under the straps on this. They might want to wash that off after the visit. But anyway, so some just general criteria of when to not bring the bag in the home. If you know that a patient is perhaps colonized or infected with an MDRO, MRSA, C. diff, I would not bring in the home. Definitely Candida auris, don't bring it in the home. If a patient's on any transmission-based precautions, droplet, airborne, contact, don't bring your bag in the home. If you are aware that the home is infested with, pests, pests, if you will, other rodents, whatever, don't bring your bag in, or it's just really not a good environment and you just don't feel comfortable. Now, the problem is the first time we make a home visit, we don't know what we are walking into behind that door, and we have to do the best we can and make the best judgment that we can. So when you are going into the home, make sure that you're performing hand hygiene before you enter the bag. Be aware of where you place the bag. And this, again, the first time you're walking in, we don't know what we're walking into. Where are you going to put the bag? Do the best that you can. Either, clean and disinfect a surface, not a wood. You have to ask the family before you go cleaning and disinfecting any surfaces of their, favorite furniture, whatever in the home. But you can always use a surface barrier that you are going to put down and first, and then put your bag on that. And so that would be one of the two proper places to put your bag. Also, too, you want to make sure, because I asked the staff, how often do you clean your bag? How often do you empty it out? When was the last time you cleaned out these pockets, whatever? Sometimes they get the deer in the headlight look. They're not doing it at all. So please go back to your policies, set a time frame. I will tell you, there are no national guidelines or criteria as to when the bag needs to be cleaned. A lot of it has to determine on how it's managed. Like on this particular visit, okay, so the strap fell off the bag, and hey, things happen. That's life. So anyway, though, after the visit, so you sanitize the strap and wipe it down, and you recover and you move on. Or you find out, you're making a first home visit for someone that does have an MDRO. It'll probably be best practice to wipe that down after you leave the home. But you do need to have policies. I might suggest that you do that weekly at the end of the week if there's proper bag management, or it becomes soiled. Typically, they don't become soiled. But those would be some good criteria as to when to do that. And also at least wiping out the inside of the bag, again, at the same frequency. You can go pocket by pocket. Managing the supplies, anything you take out of that bag, I would also put on a clean surface that's been disinfected, or also put that on a surface barrier, and to be aware of that. Now, I want to address some sort of myths, if you will, and some misconceptions, in case any of you might have any of those, because, I do hear about them. People will contact me and ask me, like, and one of a common one is that the bag has to have 3 compartments. Well, it doesn't. It would be ideal if there was an exterior compartment for, you to put your hand sanitizer that you can easily access. But if you're like me, that I like to clip mine onto my, pants, if you will, when I'm out making a visit, that works too. Or that it has to be waterproof, or there's a certain type of bag or a brand or something. No, it's really whatever works for you, unless your organization has a policy that you have to use a certain brand, or there's all kinds of really unique bags that are out there available on the internet. Some are like combo chairs, bags, recently was at a international home care nurses organization meeting, and had an opportunity to make a site visit at a hospice. And, in Singapore, all the nurses, they are using luggage, sort of the international size luggage, for making home visits. It's whatever works for you. So, as long as you follow the principles of managing the bag in a proper manner, that would be sufficient. It doesn't have certain number compartments. You don't have to have a clean and a dirty side of the bag. Everything that's in the bag should be clean. You don't want to be, and I do see this sometimes, not that often, but I do see used, like in use sharps containers that are stored inside someone's bags, and it's usually because they just didn't know. But that would be considered a dirty item. That could be stored in an outside pocket, or a lot of times people just put their sharps container in a plastic bag or some other bag, and they hand carry it in, and that's certainly efficient. So or sufficient. So that's up to you, whatever works. The placement. And this is important, go back and check your policy and see how it's written. Because surveyors, when they come to survey you, the first thing they're going to ask for is your bag technique policy. And that's what they're going to survey you on. So you want to make sure that your bag technique policy is reasonable. Some say you have to keep it zipped at all times. Well, I might respectfully disagree with that. If you have your bag up on a surface, there's no pets, there's no children, there's no airborne, drop, it's not close to a patient for droplets. I mean, everything is good. Just having that zippered open a little bit is not going to cause any problems. But again, if your policy says it has to be zipped, it needs to be zipped. Or another thing is that a regular bag can never be placed on the floor. It's not best practice, but sometimes in the homes that we have to go in, we don't have a lot of choices. So again, it would need to go on a surface barrier. Now, if there's little toddlers running around, or dogs, or there might be some other kinds of things with that, and clean, sanitize the bag afterwards. But just know there are no hard and fast rules on bag technique, if you will. It's really overall how you manage it, how you recover from the life events that happen on home care visits that we can't always anticipate. And the same thing with the rolled bag, that always has to stay on the floor. Well, sometimes it can't for whatever reason. And I do see that sometimes. Again, if you have to move it to another surface, then put it on a surface barrier and then manage it per your policy and follow through accordingly. There's also some of these bag wraps that you can put around your bag in case you've seen those on the internet. You do have to change those out every visit. Some people think they can use that ongoing and you can't. So just some common myths. Now, here are some just common bag technique compliance issues that I see. Hand hygiene not being performed before you go back in the bag, or with PPE. People have, they're in the middle of their visit. They've got gloves on for whatever reason, and they forget something and they go back in their bag with gloves on. You can't do that. Or gloves are stored directly inside the bag, or as I mentioned, a uniform pocket, and they're not in a plastic bag or in the manufacturer's original box in the bag. So that would be an area. Or sometimes, commonly, surface barriers are not used when they are indicated, or they're used for the bag. Other items are taken out, and those surface barriers are not used on those. And I could give all kinds of examples with that. Oh, another one too is there also, you might see them on the internet, these reusable microband surface barriers. And some people think that you don't have to sanitize because it's microband, that you don't have to do anything with that at the end of the visit other than just fold it up and put it back in your bag. Well, that's not true. It does have to be sanitized at the end of the visit. They're pretty large. You've got to give it some good dry time before you put that back in your bag to use on another visit. Sometimes the surface barrier size is not large enough to accommodate the size of the bag. There's all kinds of challenges with that, but ones that you need to be specifically aware of when you're out making home visits. Here's some other ones here. Now, the left slide, you'll see this was actually a home visit I was making with a nurse going into a hospice skilled nursing facility here in the US. This was in a waiting room of a nursing home. And this person put their rolling bag, you can't see that it's rolling, but trust me, it was a rolling bag. And they just plopped it on the couch that everybody coming into that waiting room would sit on. No surface barrier, nothing, and that would not be proper. The middle one, this was a home visit with a nurse. She just put her bag on the top of someone's dining room table. No surface barrier, would not be proper placement on that. The top right one was with the hospice aide going into a nursing facility where the hospice patient was receiving care. And this is how we walked into the facility with that bag. He had a shoulder strap and he just had that strapped onto his arm, and with all this stuff hanging out. And you probably can't see a lot of the detailed problems in this, but you can see like his disinfectant product. It was bad. You could see multiple compliance issues on that. Very well-meaning, intended person, but just really not good bag technique as we would want. Now, beyond bag technique, we also have to look at the process of cleaning and disinfection. This is another very important piece where we have to break the chain of infection, killing these organisms so we're not bringing them to someone else's home. One of the common problems that I see are these large canisters. The home care staff, they hate them. And they're too big. They take up too much room in their bag. And so what they do is they will, and usually management doesn't know they're doing this, but they will take out a handful of those wipes. They put them in a clear baggie like this. It's so common. It's not labeled. It doesn't meet OSHA's labeling requirements. And they put that in their bag, and then they pull them out during the home visit. That would not meet, that you have to keep it in the manufacturer's container. Some of them have individual wipes, smaller soft packs, but you cannot be repackaging equipment. You have to meet all the OSHA labeling requirements. And sometimes people forget to snap close the container because they dry out and will not have sufficient quantities of disinfectant on it. Now, the temperature, going back to this trunk storage, people, sometimes, oh my gosh, they have so much stuff in the trunk of their vehicle, and they might have multiple large canisters of the disinfectants, and they are in an environment where there are temperature extremes. And with those temperature extremes, it's going to break down. And we want to make sure that this disinfectant is going to properly work. If you are in an area where you're not going to be within those storage temperatures, just keep what's in your bag. Your bag is going to go in and out of the home. You can bring that into your personal home on the weekends, whatever. It won't be stored in your trunk of your vehicle. Some people take public transportation, and again, it maybe is not an issue, but in the U.S., many of the staff do drive, and trunk storage is an issue. The expiration date, I check for these, and a lot of times, just like the hand sanitizer, people are not aware that there's expiration dates. They're stamped on these individual packets. They're branded on these large canisters, and staff are not aware. Now, for the product that they're using, especially when they're cleaning and disinfecting their blood pressure cuffs and whatever, many times staff aren't aware that they are supposed to be using here in the U.S. an EPA registered disinfectant. And so one of the things, if you're not sure if you're using the proper item, look for an EPA registration number, because people say, oh, but it contains alcohol. Well, yeah, it might, but it's labeled. Turn that product over. Look at how that product is labeled. It might have been labeled by the US FDA as an antiseptic for use on the skin, like an alcohol prep pad. That is not EPA registered for use on medical equipment. And so that's a hard non-porous surface. So that's something that you want to make sure that you are using an EPA registered product, because I do see that sometimes with, products. The PPE, some of these products are very strong, if you will, and you need to be wearing gloves to protect yourself. And the staff are not aware of that, and they're just pulling out, wipes with their bare hands, and they are, through their skin, they're getting all those chemicals, and that's not what you want. So you need to be aware of whether PPE needs to be worn. And I'd also advise you too, because I have seen this in some manufacturers, they'll say specifically, gloves don't need to be worn. And then in another sentence on the same label, it says avoid contact with the skin. So if it says avoid contact with the skin, I'd be wearing gloves when you're going to be cleaning and disinfecting products with that product. Now, the contact time, this is very important. Excuse me. Staff need to know the manufacturer's contact time for that particular product. Is it 1 minute, 2 minute, 3 minute, whatever? They need to be aware of what that is, and they need to be aware of specifically how they are going to meet that. Because, especially, let's just say, to give you an example, like during COVID, okay, so I'm out making home visits with the staff, and I had a face shield on. And of course, I have to be the good role model, and I'm at the trunk of the vehicle. I've got my gloves on. I'm going to be disinfecting, using their products and supplies. Got a 3-minute contact time. Well, and I've got to hit 3 minutes, and we're out. Oh, it's August, and we're in the South in the United States, and I have to hit 3 minutes, and you're there wiping and wiping and wiping, and 3 minutes is a long time when you are trying to achieve, because you've got to keep that product wet for whatever the contact time is that the manufacturer requires. So please be aware of that. Have some kind of mechanism in place for you to know, how long it's going to take for that to dry, because we don't know in people's homes, the humidification levels, the temperature, humidity, all of that is going to adjust how fast something's going to dry, and we need to potentially re-wipe things multiple times in home care. So be aware of also being able to implement first aid measures, because when you're popping that out, if you get a little splashback of that in your eye, the manufacturers typically say you have to rinse your eye for 15 to 20 minutes. Well, how are you going to do that in someone's home? We don't have eye wash stations, and I'm not proposing that you, you know, have, no, you're not going to have enough liquid with you to have a 15 to 20 minute, rinse of your eye to meet OSHA requirements. You can buy these little silicone plastic cups for eye rinse cups that people could use on a home visit to safely implement first aid measures as needed. So just, please be aware of that. Now, when you are going to be managing your equipment and supplies and making the home visits, be aware. Now, in the United States, for electronic visit verification purposes, this was a federal law that went into place. In home care, we have to have patients sign off that we were there to just, verify that the home visit was conducted. So typically, we will have our patients or their families sign, cell phone, tablet, laptop, whatever. Now, here's the breakdown. So we've been documenting perhaps on our cell phone, whatever our electronic device is, and then at the end of the visit, it's time for the patient to sign the document, and they don't even wipe it. They don't clean it. They've been touching it the whole time. They just hand it over to the patient. Well, guess what? They now might have done, a touch screen, or maybe they used a stylet, whatever. They now have those organisms on their hands, whatever was on that surface, and we've not provided them an opportunity to perform hand hygiene after. And then they can self-inoculate themselves and acquire whatever organisms they might have, been transferred to them. So this is really important, that either we clean and disinfect those electronic surfaces before we hand it to them, or, and it's a good, teaching moment too, that we provide them, with some hand sanitizer after, and, use it as a teaching moment to make sure they're performing hand sanitization properly for the right length of time. Because sometimes, depending upon the organism that might have been in the home on that visit, we need to make sure they're washing their hands. And I could give you lots of examples with that. But anyway, now what if you are caring for a patient that has some type of MDRO, a multi-drug resistant organism, or perhaps C. diff, or Candida auris, or some of these, how are you going to manage your devices and cleaning and disinfecting? Well, first off, just to tag along with bag technique, I would not even be bringing your bag in on those particular home visits, because we don't want to expose anything during that visit. So, the vital sign equipment, we still need to be checking patients' vital signs. My personal suggestion to you, here's the hierarchy in which you're supposed to follow. The first choice is disposable. Now, I get it. Disposable vital sign equipment, it's expensive. People can't afford it. Okay, maybe that's not the best option for you. Second best choice is to dedicate equipment. That means when you are aware on the first visit, you bring in vital sign equipment that you are going to dedicate or leave in the home, and you leave that there for however, whatever length of time is that the patient is going to be receiving care. So then that means that every staff member going in, they can leave their vital sign equipment in the car because they know it's already in there. And they use that equipment. Then at the end of the last discharge visit, then whoever's the last one out, don't have that person be the one necessarily to disinfect it. Maybe, bag that up, just really do a good job, tighten that up, bring it back to the office, and meticulously clean and disinfect that, sanitize, disinfect those equipment and supplies before they are put into reuse again for another patient. Because again, this equipment that we are bringing from home to home, this is where we're transferring organisms, and we don't want that to happen. Now, here's just, some compliance issues. These are some images I've taken along my travels along the way. Now, here in the US, we may be monitoring patients PT INR in the home with the ProTime machine. Now, on the far left-hand corner, this is the PT INR machine. There's a little blue strip on the bottom of that that's been popped off, so you're not seeing that in this image. But one of the things that the staff are supposed to be monitoring for is that there's not like blood accumulation under there. Well, I find this commonly that staff are not aware that they need to clean and disinfect, or not disinfect, sanitize this particular strip area. And this is not what you want to see when you pop that off. Different staff member, whatever, but on the next picture over to the right, following from left to right, these are the ProTime test strips. There was blood all over the outside of this. Now, I have no idea how that blood got there, but there's probably technique problems there, and that should not be in someone's bag that they are out using in the home. The middle picture, this is from a hospice IPU. Unfortunately, many with our patients at end of life, or even not end of life, but with COPD and other illnesses, they have air hunger, and we provide them with fans in the IPU. Not patient-owned fans. I'm talking about hospice-owned fans that were responsible for the maintenance. Again, because I look at the maintenance issues, whose equipment is it? The standards are different. Now, when it's an organization-owned piece of equipment, seeing this level of dust and accumulation on this is not acceptable. This could potentially, transfer to the patient, others, in the direction and blowing airborne pathogens to them on the dust particles. It's just not acceptable. The next one over, this was a home visit. These next two, they're separate patients, but oxygen concentrators, that's another area that I see is problematic, that we are not properly teaching our patients how to manage these humidification jars. I mean, this one here, it was just, it was awful. It was molded. The one on the far right, this is an older model concentrator, but I do see this. Especially now, some of the newer models don't have external filters, but if they do, many of the patients, their families, they're not aware that those are supposed to be, washed, dried, cleaned every week, and they're just not keeping up with it. So that's something that we need to be, reinforcing to our staff. I've already talked a little bit about equipment and supply management when it comes to trunk supply management. Temperature is number one. Where is this? If you're driving, if you do take a vehicle from home to home, what are the temperature conditions within which, you can maybe just group all these things that have to be stored at a certain temperature, put them all in a certain bag, a little plastic bag, especially those with expiration dates. You should be going through this trunk minimally once a month, the end of the month, because that's when the expiration dates are going to go out. Look at some nurses have be like the national stockpile in their trunk. And if you keep all these things that have expiration dates on them together, maybe just in one of the two compartments, it'll make this whole process go much faster. But you want to keep your inventory to a minimum. If you look at the CDC guidelines in a healthcare facility, they state that sterile supplies need to be stored at 68 to 77 degrees Fahrenheit with 30 to 60% relative humidity. Do you think we exceed these temperatures and humidity levels in a home environment, in a just general environment? Absolutely we do. We need to be keeping trunk stock to a minimum, rotating through, and being aware of our bag content. Now, as far as the bottom line, people ask me, well, what do I have to have in my bag? Well, you can put whatever you want, But I'm going to give you the must-dos. This is sort of the bottom line. Make sure you've got this in your bag. You need to have your soap, hand sanitizer, hand drying material, you know, disinfectant products, and then as far as PPE to meet OSHA requirements, you need to have at least one set of each type of PPE, whatever you would be required to use. So some staff are not CPR certified. The agencies don't want them performing CPR. So am I going to be expecting a one-way valve mask? No, because that's not something they do. However, if CPR is within your realm and scope, yes, they need to have that. Because some people say, oh, well, I've got that in my trunk. Well, you need to have that in your bag. We in home care, we cannot always anticipate what our needs are going to be, and we need to have that immediately accessible at the point of care. Now, as far as managing medical waste that we're generating in the home, it's really two different types. It's either, medical, regulated medical waste that we're going to put in a red bag. Typically, what we see is sharps waste. And so that is going to be managed in a sharps container. Talked about where to store that. It's going to be stored in the trunk of the car, but I want to mention specifically where to store this waste in the trunk of your vehicle. I would get don't I see cardboard boxes, and unfortunately from my personal experience, I've opened those up and it looked like a big puddle of blood in there. The sharps container tipped over. Anyway, it was not good. If that was in a cardboard plastic bag, that would have been sort of a big mess. You want to make sure that you're using a hard plastic container with a lid. Just use some solid method that there's not going to be a transfer into your other clean supplies. You could have empty sharps containers in with your supplies, that's fine, but just not an in-use one. So we're going to be transporting that to the office from the home, and then putting that in the storage area for pickup by a biomedical waste company. Now, this particular nurse that I was out with her, I didn't set her up. I didn't say, "Oh, I want you to kneel on the ground. I'd like to take your picture." No, she just did this because a lot of the staff in home care, we're doing the best we can with what we're walking into, and many of these places there is no place for us to sit, or sometimes we don't even want to sit. So we need to be very aware of risk levels and contaminations of our clothing, because in this particular case, the clothing becomes contaminated, especially with the aides when they're leaning in and they're leaning over our patients, giving a bed bath. I get it. Sometimes the nurses need to, bend down to do foot care, do wound care on some, it's a long time to squat down. I get it. It might be hard. But there's all kinds of great new little portable chairs that are available on the internet that you could just bring that in. They pop up. You could sit down instead of kneeling. There's all kinds of things that are available now that were not out there. I know it might look a little, I don't know, awkward or weird, if you will, to maybe pull out a surface barrier to kneel on, but you've got to follow something to break the chain and not be contaminating your clothing when you are out making home visits, to be aware of that. Now, my personal favorite out making home visit are the pets that, people's pets they have in the home. And, we just need to be very aware of this. Now, some people are very guarded, home care providers. A lot of them now are setting policies that they want their animals put away. It can't hurt, but I will tell you, sometimes they get pushback from the patients. They want their animals, their dogs, cats, whatever, they want them with them. And, you can make the decisions on that. But if you do have pets, dogs, cats, whatever, that are present during the home visit, better be aware of how, I'm sure you guys know, you've seen it, the cats that walk through the sterile field, they want to sit on your bag, or the dogs that want to sniff into open bags in the home. They do all kinds of things. What if this patient, had C. diff and look at their dog on the left-hand corner? I mean, hey, I've had dogs. Anybody who's had a dog knows that, yeah, they might do this. But can you imagine the environmental contamination if the patient had C. diff and that was their bathroom? This particular visit on the right, for those of you that are listening in home care, we all have our patients that will forever go down in our mind, in our home care careers, and this was one of them for me. Oh my gosh, I was out with a home care aide, and this man that she had to go out and see to clean up for him, he was so large, physically large, that he would be the man that the fire department would have to take down a wall in the house. And this aide had to go in and care for this man. God bless this aide. Anyway, while she was away for a moment, carrying away 6 jugs of urine that this guy left for her, the cat, she did such a good job setting up her field. The cat decided to come over and sit on all of her beautifully set up field. And she didn't know that this happened. Well, of course, I had to take a picture and show her. But I said, oh, honey, you didn't know that this happened. And you get an A+ for this visit. We don't care what happens. I said, you know what? This is what the cat did. Take this down, start over, and just, start over with your visit. So please be aware of this. You know what? We love the animals, so you might pet them, whatever. Just be aware that there are studies, there is data that shows that, if a patient's colonized with an MDRO, it's likely that their pet is also. They can transfer that between each other. If you use good hand hygiene after you have contact with an animal, perform hand hygiene, and that would be generally sufficient. But just be aware of that when you're making the home visit. Now, as far as the hierarchy of how you're going to set your policies, there's really just a couple things I want to highlight for you on this slide. First off, the bottom line is you've got to follow any U.S. state, local laws, and state regulations. You have to know what those are and then follow them. Then you follow federal OSHA, CMS rules. But here's the one that trips people up. They think they're supposed to follow the CDC, World Health Organization guidelines next, and you're not. They're supposed to follow the manufacturer's instructions next. Then you follow CDC, the other evidence-based guidelines, accrediting organization standards. These are actually examples of several books I've written, the dark red and the sage green one on the bottom. Those are the APIC endorsed books, and the one on the top left is the one I've been writing since 2006. So, but this is when you are writing your own documents, guidelines, your home care organization's policies and procedures, this is the framework. So you've got to go back through your manufacturer's instructions for use and know what those state. Be aware, because many of them are not reasonable. That's a whole other conversation, but just be aware of them at least first and follow good practices. So, as I mentioned, infection prevention begins at the front door. These are the patients that we, are trying to protect. God bless this woman. She died a couple of weeks after I made this home visit with her. She needed wound care. She was on home oxygen. And we need to be so sensitive to not transferring and bringing our potentially pathogenic organisms into the home. So I hope that you've picked up some, potential practical strategies, tips on things that you can follow to help break the chain of infection and to keep our patients safe at home where they most want to be. So I'm going to go ahead and transfer this back to you now, Martin, in case you have any questions, and we'll go from there.
Thank you very much, Mary. As ever, a fantastically practical session born from experience about how people can actually do things in the real world. Because as you, I think, highlighted a few times, policy and procedure may say one thing, but actually trying to get it done in the real world takes a bit of creative thought. I just have one question, really. And I've never met anybody who cares for others deliberately make mistakes or go out to cause harm. So, is education a real challenge in this sector? And how can people access the best education that will help them improve their practice?
Yes, yes, absolutely. Because education is so important because, nobody is, the policies and all of that is great, but unless the staff know what to do when they are out in the home to prevent the transmission, we are going to transfer organisms and potentially contribute to home care onset healthcare associated infections. And that's what we, are trying to do. So, education is so important. And so that's why I really support, you and Paul, and congratulations to the 25 years of education and truly making a difference and offering this education for others so that they can improve their patients' safety and improve their own personal practice and really make a difference when they're out there. Education is absolutely so important.
Thank you very much, Mary. Well, it's been another fantastic session. I've really enjoyed it. Lots of really good points, especially with regard to the bag hygiene, actually, because I used to have issues where people shared a bag and people just come and drop it in the office, and somebody else who was going into home care would take on that bag, and didn't seem to be anybody's job to actually clean it. So there's some issues there, I think, also potentially. Paul, could we move on to the next slide? Yeah. Okay. So just to highlight the upcoming sessions for the Weber training lectures, this is 25 years anniversary. Of course, we've got an IPAC Canada conference broadcast on environmental stewardships in IPAC with Dr. Fiona Miller coming up on the 26th of May, followed a day later by another IPAC Canada conference broadcast, misinformation and disinformation, the next pandemic, and we've certainly seen plenty of that over the last few years. Interestingly, that'll be a journalist who's giving that, so that's from the horse's mouth, if you like. We then move into June, where we've got an Australasian teleclass with Kathy Dempsey. Now, Dr. Kathy Dempsey, congratulations to you, Kathy, who's talking about infection prevention and control response and escalation frameworks. And further on into June, we've got monitoring and evaluation to optimize microbiology and care with Pramit Sheth from Canada. As ever, we thank our teleclass education patron sponsors, without whom teleclass education could not take place. So that's Diversi, Pyrox Technologies, and now the International Federation of Infection Control. Thank you very much to everybody. And thank you, everybody, for joining us. Thank you, Mary, and look forward to speaking to you again.